in 2023, we did see some changes in the adoption of DCTs. What I think is happening is that they're becoming more normalized. So first, let's be clear. DCTs are really a set of methods that allow you to change the way the trial is executed. It's not a whole new discipline of clinical trials. But that means you get to choose which of the methods are useful in your setting. It's not going to look the same across every trial. And I think that early in the pandemic, people did assume it was all the same and this was an all or none sort of a situation. I think what's great is now we're normalizing it. So we're building in optionality and thinking about how the new methods fit in the situation where we're running the study. So the challenge is, frankly, these methods are not documented in consistent ways in systems like CTMS or even in clinicaltrial.gov listings, and so the data can be a little bit hard to get and sometimes difficult to interpret. There are some things that do work in a fully virtual setting. They're more limited, let's be honest. A lot of the endpoints and assessments still require human-to-human interaction. Not all of that can happen in the home. And so I do think you're going to see an increase in both sets of methods, both fully virtual and hybridized, but we're going to get more sophisticated about what fits where. So let me give you an example. Diagnostic trials actually work really, really well in a virtual setting. But rare disease trials may be those sorts of trials where you really do need the PI's oversight for some very specific endpoints, and you could do some things from the patient's home, or even a patient could manage things with their pharmacy as a clinical trial site. So once again, it's all about taking the Lego blocks of DCT methods and making them fit to what you're trying to build. I want it all. So I think the regulators are sending very clear signals that this is something they want and they want more of. Second, I think we do need that operational data to help people understand where there is a difference and how you can achieve it in which settings. That isn't whether or not the trial was successful or not. It's more about, did these methods actually help achieve the trial's cycle time? And then third, I would really like people to reframe their thinking about DCTs. DCTs are not about technology. At their heart, they're about access to trials. And that is a systematic way of thinking, including the sites, the technology, the service providers, and the patients themselves. So how do we enable access to clinical trials to drive decision-making faster about whether or not therapeutics are working? That's what DCTs are for.